Okay, so I think going back to the start, we budgets are under pressure. There is a lot on politicians and policymakers' agendas which don't relate to our concerns here necessarily, and so fine words and fine documents can be created on what our aspirations might be around cancer control, and are created, in fact. And the solutions to actually implementing them are fiendishly complex and difficult. There's a lot to cover. I mean, there needs to be funding, there needs to be the right policies, and then we need to have the actual delivery services and the ways to make those efficient. But what I'd like us to discuss in this session is the big picture key enablers that enable that translation between those fine words and fine aspirations and actual effective and cost-effective delivery in a constrained and stressed environment that we see. So let me start with you, Tula, from Finland. You have hands-on experience of this in Finland. What would you say in response to that question of the key enablers that you've seen to translate?
Thank you. Very, very good question. But if I start, if I may, so referring to tilt upwards, I think that one of the things is the not only the top down, the bottom up issues, the initiatives. So I do remember when I was working on the Helsinki University Hospital, very big hospital, 26,000 people workforce in that hospital, and one of the units were cancer center, and we were struggling in a way, not only about the resources, but as well that we need something must be done. And we then applied to this accreditation program by OSCI. And I do remember the day when they said, please welcome, and we received 950 questions. 950 questions. You can imagine a lot of work, and everybody almost paralyzed that who in the earth is going to answer all these questions because we are taking care of patients. So, but at the end, I think it was something like almost 4 years it took, but then we luckily received the comprehensive cancer center status, but it was very beneficial for us all. And I think that in a way showed to the politicians and to the government that the results, I mean, that something must be done and can be done. And in that day, the government said that we have to, because there were 5.5 million people in Finland, but if you think about the surface area, it's not that small. So if you think about the borderline, I'm not going into detail about the preparedness at the moment and the global situation, but our borderline is 1,350 kilometers with Russia. So, but anyhow, so it means that usually I say that it takes 16 hours from the southern part of Finland to the Lapland where the Santa Claus lives. So that and the question was that how those people living in those rural areas, do they have the same possibilities to get the best treatment comparing to people living in the university hospital area? And as we know, no, they don't. And so that was the big question for the politicians, and say that, yeah, we have to build up a national cancer center so that all the university hospitals, not only that, but the faculties having the medical faculty as well must be integrated, and the third sector, so that the patient organization. And so it's in a way, we need both the bottom up and the top down, so that we can really deliver the nicest results. But then, of course, we need the legislation, we need the finance, and I think that now from the perspective from the ministry, the government backing is very central, so that we can support the national guidelines, we can support the national cancer plans and strategies, and we can in a way trying to build up an enabling legislation and of course then support by financing the situation. And the registries, of course, the data is everything, but I think we come to that later.
Yes. Okay. We'll definitely come to that. And a question that I'm going to ask you is how you maintain that government backing, but I won't ask you now, but there's time to think about that. Bob, From your perspective, AstraZeneca, or representing the industry, what do you see as key enablers that enable that translation between our aspiration and actual delivery? Well, how do we go about that?
Thank you. I'll give an industry perspective as well as maybe an academic perspective, having served at Memorial Sloan Kettering Cancer Center as a physician scientist for over a decade, having just joined AstraZeneca 6 months ago. So I think the key enabler is actually a mindset. In order to do implementation right in Europe, it's really a mindset of investment, openness to innovation, and to see investment in health as not a cost expenditure, but really a sustainable program with return on investment for economic growth and development. And I think The Economist bringing this World Cancer Series is really an example of that good mindset, bringing that attention to all the leaders in this room, the really true stakeholders of influence at the European Commission. But if we really look at cancer, it's on track to be the #1 cause of death in all of Europe by 2035. It's already the #1 cause of death in half a dozen countries, including right here in Belgium, including France, including the Netherlands, Spain. So this is a problem that is going to affect all of us. And most of us have a family member, a loved one, or a close friend who's really been affected and lives turn upside down, no matter what position you hold. So this is an urgent problem. But if you look at the cure for cancer, it requires clinical trials. That's the critical step of translating all the discoveries and innovations in biological science, whether it's treatment or prevention, and turn it into something that can save lives. On the market, ready to go for patients. It's a clinical trial science. But clinical trials used to be really originating from Europe. When I was in medical school some 2 decades ago, Europe was really the powerhouse for clinical trials, at least on equal terms with the United States. But now that number has dwindled. It's really on a sharp decline. If you look at 2013, the European share of clinical trials is around 22% of the whole world. And 10 years later, 2023 numbers, that number is now down to 12%. And it's on that downward trajectory. At the same time, there's exponential rise in Asia Pacific, and the United States is still holding high and going strong in terms of investment in innovation. And the times are really changing rapidly. Having just left practice 6 months ago in New York, this is really the age of AI revolution. My patients were calling my office as of 6 months ago. They're leaving a message saying, I've already seen my radiology report, and I got my ChatGPT to scan the results. And the ChatGPT says, my cancer's shrinking. Dr. Lee's doing an okay job. I don't need to change a doctor for now, but in the future, if my cancer progresses, it can help. So just leaving a message with my office. So I'm getting that, is this correct, Dr. Lee? And I haven't even had a chance to read the report of the patient. They're already onto it. It's like when Mark says that every patient in Northern Ireland has their records on smartphone. This is already happening today. And if you give it another 6 months, 12 months, 2 years, you imagine really the patient empowerment in the digital information's age. And that's going to leapfrog. So in America, there's a major shift from comprehensive cancer centers. I'm glad that there is a European dedication to that. That's a model that's worked in the US. It's really commissioned by President Nixon in 1971 with the National Cancer Act. That's the NCI designated comprehensive cancer center model. There's more than 60 of them in the US, Memorial Sloan Kettering being one of them. But that model is about to change. There's a paradigm shift where the patient is at the center, not the cancer center. So the cancer centers really have to play a role as hubs, empowering the spokes through technology, through innovation, through partnerships with local community docs to supply the innovation, whether it's drugs or prevention or vaccine, to the patient wherever they may be. So that's a fundamental shift from cancer center to cancer networks. And clinical trials they bring a lot of economic benefit. It's already published. In Europe, it's about 1.5 billion euros every year in terms of direct benefit to the healthcare system. And then an Austrian study published recently showed that there's secondary benefit at least twice that number in terms of cost savings, the pay and the economic benefit of these patients getting better and living economically productive lives. So I think in Europe, talking to our European colleagues and partners who are really burdened by the paperwork, they say bureaucracy, and they say just their time is consumed filling out forms, the 150 pages, and not taking care of these patients. And I think these are fixable problems, whether it's the clinical trial regulation in EU, which is an incredible project with very good intent to harmonize different member states and put it in one system. But because of the bureaucracy and the paperwork, it's become a really burdensome process that actually delayed clinical trial startup time rather than shortening it as originally intended. The in vitro diagnostics regulation also put a lot of burden, the IVDRs, in terms of getting any trial activated because the assay needs a lot of regulatory review and approval. So rather than a mindset of control and regulation, but perhaps a mindset of empowerment, empowering the clinicians, the patients, the member states, and an openness to economic development and innovation. Because Europe has really a really solid foundation. And when we talk about cancer center to cancer networks, Europe has one of the greatest universal healthcare systems in the world with a really good, rock-solid safety net. So when we want to leapfrog, if everyone in Northern Ireland has their data on their smartphones and privacy protected and everything, imagine doing it across a pan-European project and really empowering every European patient to really leapfrog and attract investment, the economic benefit it will bring. So it's really, I think you got everything that you need, but a changing mindset. And I think there's so much innovation in all the pockets in Europe, and that could really unleash the full potential for the benefit of patients and the cure for cancer for the whole world.
Okay, great. Thank you, Bob. So I'm just going to tally up what I've gleaned so far, just so we're looking at these big picture enablers. It's keeping up the momentum to keep cancer control on the agenda in terms of in politicians' minds. The finance and the legislation being in place. We've also heard about cancer networks. So there's standards around them, but they're being delivered for the purposes of equitable delivery. A thriving R&D landscape enabled in part by appropriate levels of bureaucracy, which sounds like they've gone over the top, you're saying, and an unstoppable movement towards patient empowerment, thanks to a lot of the AI tools and things that are available, and patients taking control of their own health. So that's what I've got so far. You can add more as we go. So Mirella, let me come to you then. Again, the same question, the enablers of that translation from aspiration to policy.
Okay, as a cancer surgeon, I see the gap between policy and reality every day. The question is not just what we develop. It's how we implement it in a way that truly reaches patient. For cost effectiveness impact, we need three things. One, functional care pathways, not just innovation. Biotech and I are powerful, but if we don't have trained staff, integrating teams, or reimbursement in place, the patient never sees the benefit. Two, multidisciplinary certified centers as standard. They reduce delays, improve outcomes, and make smarter use of resources, especially when combined with navigation program and mental health support. Three, patient voice must guide decision. Prompts and PREMs should be embedded in national system. They help us focus on real-world value, not just clinical data. So the key for the audience, innovation without implementation is wasted potential. We need systems that turn ambition into access. Certified multidisciplinary cancer centers are essential for both equity and quality. Prompts and prims must become standard to align care with what matters the patient. Digital tools and AI must close gaps, not widen them.
Thank you. Matt, I know you've got a lot to say on proms and prems, and I think you're probably going to talk about the data, which Tula alluded to. So go ahead, this as an enabler again to ensure that our aspirations are actually delivered upon.
Yeah, so there's a couple of terms I'm going to pick up on, proms and prems, vital. The voice of the patient.
The voice of the patient.
The voice of the patient, who is central to everything we do, isn't being listened to in many cases. It is in front of the clinician, but it may not be when it comes to tracking and monitoring the benefit to the patient of that innovation as they see it. So that's vital, number one. And Bob, you talked about enablement. So a couple of themes I'll pick up on really is around how we talk a lot about we must do X, Y, and Z with data. We're collecting data. These data are important, particularly when we're looking at clinical trials. But if we take the perspective of what data enables decision makers, particularly those who hold budgets, because we heard in the last talk about, money's tight, hey? So I was responsible for overseeing over 175 hospitals, a significant budget, and I had an innovation coming to me every day. We've got the largest pipeline of innovations coming out of the FDA in history in cancer. How do you rationalize that spend when some of the innovations we deal with clinically today don't even have good evidence behind their efficacy? So it's around rationalizing the data to prove value in two terms: one, to the patient and the outcomes that are important to them, but also the outcomes that are important to the economy, because the money has to be rationalized. So if we talk about the fundamental principles of value-based healthcare, one of the key things I ask for is value to whom? What perspective are you putting on when you determine this is the best care for this patient? Is the patient being kept well? And that's one of the things when we talk about disease-free, progression-free, overall survival, etc. They're great metrics, right? But what if the patient isn't well? What if they're not able to go back to work? What if their life has been destroyed by this treatment, but they're still alive? So some of the metrics need to be carefully checked for the purpose of what we're looking at from a decision perspective. And then the last thing, of course, is, one of the conundrums I had on any given day is I would get a really good clinical efficacy report from a new innovation. I then have to rationalise that to a chief financial officer as to how I'm going to rationalise that spend. Almost always, there's no economic analysis. And that made my job really difficult to rationalise spend and to bring this new innovation into the marketplace where it had no proms, no prems, or very limited, or the proms and prems didn't track, or there was no mechanism for tracking and monitoring that patient after the treatment innovation was delivered, and into the long-term real world to say, did this innovation deliver long-term return of investment and improvement of the cost of life? And that was the bit that I was really struggling with. So the data, right at the inception of the trial, needs to be designed with the decision maker at the end, who's going to determine whether they will and will not fund this drug to give it to the patient to get a better outcome.
But it's not only about innovation, is it? We need to be tracking. Surely the data is important for actually tracking day-to-day interactions as well, to make sure we're doing the right thing, even with the stuff that we've already got in the system. Is there anything you want to speak to on that?
Well, yeah. So I think
any of you, by the way. Yeah. So
yeah.
Go ahead. Yeah.
So I'll finish the theme because I think that's picking up on the efficacy again. So if we look at OECD, 20% of innovations don't give a clinical benefit or even might cause harm, or World Health Organization, 40% of innovations or health delivery
health delivery, I think it is.
Yeah, health delivery are wasteful. there's 20 and 40% sitting right there as opportunities. So think of this as an opportunity, I guess, is what I'm trying to say. But yeah, I'll pass it.
Yeah, I think what Matt said about real-world data and generalizability is very, very important in terms of assessing actual value of the innovation. And we traditionally base policy decision on randomized phase 3 trials, which is like hundreds or sometimes thousands of patients, and then you compare one group versus another, and then you get a result. But these thousands of patients are unique individuals. They're not all the same, and they benefit to varying degrees. When you say a median progression-free or overall survival benefit is one number, that's one person out of a long range of patients. So the individualized benefit is very different to the median survival. So I think the time has come really for real-world evidence to be adapted and adopted. And in the age of AI revolution, we published a paper with my previous group at MSK. Instead of having fellows entering databases into sort of Excel sheets 2 a.m. in the morning, the AI can do the same job with equal accuracy. Not 100%. The fellow makes mistakes 2 a.m. in the morning as well, but the AI does too. But AI can improve and do better. So that real-world data capture is going to be more. We heard that patients are willing to share data for the benefit of mankind and for their own benefit as well as the benefit of the world. So, of course, their privacy needs to be protected, upheld above all or else, but there's a lot of mechanism that we can share data anonymously and get that data through a pan-European project of data sharing and to really answer these value questions that Matt just posed. So at AstraZeneca, we're really doing a lot of investment into real-world evidence, into technology adaptation with AI support. And it has to be a public-private partnership with government registries. We can't own all the data. We have to be a partner in this exercise so we can support, provide tools, provide investment. But it really needs to be championed by academic investigators, government policymakers, and patients to really get that ecosystem or data lake so that we can answer these questions in real time. I ask a question in the morning, I get it by midday, an analysis. So that's the kind of movement that we're going to, and it has to be equitable. It can't be. We heard the ageism question, and I think we have to go past that. The innovation needs to reach all patients. And it has to be generalizable to all patients, no matter who they are. So I'm pretty proud at AstraZeneca we have clinical trials. We're accruing patients well into their 80s. And when I was practicing at MSK, my oldest patient was 95-year-old and still was a cancer fighter. And his life was saved and being prolonged because of a clinical trial, and he's contributing data to the greater good so that some other patients' lives will be saved because of his fighting spirit. So that's the whole point about health equity, how that's such a sustainable strategy, and that real-world evidence will play a crucial role. Yeah.
So, Tula, I'm going to ask you in a minute, but so at root, though, what we've been talking about recently is about data being critical. If we talk about the aspirations we have for cancer control, data is critical to say whether we are actually delivering on those aspirations, how well we're delivering it, and how we can improve in the future. I mean, that's the purpose. And without that data flow, we have no idea. So, Tula, you wanted to come in. And by the way, I'm going to keep the panel going for another 5 or 6 minutes from here, but then please prepare your questions. We'll leave a good, you're a very vocal bunch, I know. So get your questions ready and we'll have a good 15 minutes for questions.
Yeah, well, as we heard, the cooperation is the key. So, but at the ministerial governmental level as well, because we noticed about over 10 years ago that this is not just a question to Ministry of Social Affairs and Health, and the government decided to establish health sector growth strategy, which said that the ministries which must be involved are not only our ministry but the Ministry of Education and Science and Culture, and Ministry of Employment and Economy, and Ministry of Finance. So that that was in the idea that we have to, as referring to the innovation and to the RDI, so we have to have the whole package. So that and I think that was in a way the turning point, so that not only the government but the civil servants and everybody understood that this is really a collaboration between all the sectors. And then came the financing. So then the government decided, okay, this is not enough. We have to have more on board as well the two big research financiers, Council of Research and the Business Finland, and they were on board as well. So that, and this has stayed over 4 governments already. So every prime minister has said that this is the way to do it. So that, and that involves that because we have all the sectors, so that the data, as we know, we are talking about the personalized medicine, as we know, if there is no data, there is no such a thing as personalized medicine. And now I am referring to the genomes and omics. And as you very nicely point out, one of our question has been that how is it so that we lack courage, so that we are thinking about the legislation too much, so that and the privacy, and as it was stated that the patient want to really share the data. But I must say that if you ask these questions from the citizens, the answers are different. So it's good to keep in mind, so that it's interesting. But anyhow, so that we build up and just referring to the AI and to the supercomputers. The question was that, okay, we have a genome, so there is a big initiative, 1 million genomes in the EU level. Then the 26 European countries have signed the declaration, and the question was how to really share the genome data. As we know, it's very sensitive, highly sensitive. So we decided in Finland that, okay, we build up a synthetic genomes. So it was they were just let's say very openly access that you get you can collect about 10,000 genomes, and then you in a way evolutionary you copied in that way that after the all the copies then you have over 1 million genomes, and then they are in a way very nicely you can teach the AI with that because it's not identified anymore. But the question was that okay, how much space does all this? We have 1 million genomes and some of phenotypic data, and we have the supercomputer in Lumi computer in Kajaani, Lapland. And I remember the day when those IT guys they called me and said, okay, now we have the over 1 million genomes, and on the phenotypic data, it's about, when we pack it, it's about 50 terabytes. Okay, that's not much. But they say, but when you open it up, you have to open it up. It's 200 petabytes. So then you can imagine how to really, where do you use all these data? And then he said, you can't touch upon that 200 petabytes because it's raw data. You have to copy it, but then you can do what you want. Then you have 400 petabytes. So I think that that is one of the things that we need these kind of a pilot, so that you can really show what are those limiting things and what can we do. Even it's a sensitive data, we need the pilots and the data so that we can now in a way do the rehearsing how to use the omics, the benefits, and not only the patient but the citizens as well who have, for example, high-risk genes.
So that's really talking about the risk of being overwhelmed by data. But if we're careful about what questions we ask, we avoid that risk and making sure we're asking the right questions.
Yeah, right.
Before I go to questions from the floor, Mirella, I want to address this question of bureaucracy in trying to deliver things. You're on the front line. Do you find the bureaucracy is increasing? How do you manage that, and where do you think the balance lies, I suppose, in terms of doing the right thing, making sure things are well documented, but at the same time having the freedom to operate and to improve care?
It depends of situation. Mm-hmm. It depends of patient. It depends of many things. Mm-hmm. It's difficult to answer.
Okay.
Yes.
Okay. All right. Fair enough.
I want just hope to learn how the tech innovation are being translated into real care, especially in underserved areas.
Okay.
And ways that embed mental health into national cancer strategy. In the public-private models that balance cost with patient impact. Policy that fast-track access and reimbursement. Ways that I say, models of public-private collaboration that deliver measurable outcomes. Example of policy and regulatory flexibility that speed access without losing quality. Strategy for sustainable funding linked to value. I hope to learn.
Wow. That's a lot of questions to cover. Is there any one of those any of you like to cover?
I think public-private partnership is really extremely important. There's no one stakeholder, institution, enterprise, government that can eliminate cancer. You cannot fight cancer alone. It's really a whole of ecosystem with partnership on clinical measures, on regulatory, on policy, in access, in sustainable development. So it is complex, but this is a time of unprecedented technological transformation. And yes, there's division in the world, but there's also hyperconnectivity as well. So I think there's an opportunity upon us, especially here in Europe, based on solid foundations in healthcare, that we can leapfrog and really eliminate cancer as a cause of death, despite the mounting challenges.
So yeah, brief comments from both of you. I think both Tula first, and then Matt, and then I think we need to take some questions from the floor. So Tula, you go.
Yeah, I think that one of the things is
brief, please.
that we build an healthcare ecosystem where we in a way we identify all the stakeholders, including the companies, and that was one thing, that we have the ecosystem, and the other thing is that I'm a pilot person by myself, so we build up on pilots so that with the collaboration, I try to in a way figure out which is good or not, which is working, which is not, and I think that one of the things is which is very good collaboration with the big pharma is the FinGen project. So FinGen, which is I think it's at the moment something like 150 million euro project. So there are many pharmaceutical companies, and we have those biobank sample which from 500,000 people, so that there is a very good collaboration. And of course, it's anonymous data, but it's very good, the collaboration. I mean, we need the pilots.
Matt, go ahead.
I want to pick up on something you just said, Bob, about public-private partnerships. It's an interesting dynamic between the public system and the private system that may or may not interconnect, and particularly where the private system might be an opportunity to incubate an innovation, prove its efficacy in a slightly more agile, potentially less politically constrained, shall we say, opportunity. And we've been working with the Health Value Alliance with private sectors and insurers right across the world, is bringing together collaborators to say, okay, we can actually do this in this setting, prove its benefit using an economic model on the same population effectively, and showcase that at least that concept of economic value and patient-centric outcomes and longitudinal risk prediction and decline and reduction, to showcase that back to the national service to say, look, it can be done. And surprisingly, on very little data. And that's the thing, because data was always a reticence. And we go, actually, most of this information is collected routinely in your electronic medical record already.
Right.
So let's use what we've got before we start getting too explosive on our data request.
Right. Okay. I mean, this comes back to Bob's point about mindset, because many of these things we're talking about the right balance is enabling access to data without being hindered by GDPR or those sorts of regulations, enabling experiments to take place, innovative experiments, which of course run the risk of things not going to plan. But it's a mindset shift, and if we've got data, we can at least track how we're doing against these things. It de-risks those experiments. Okay. Got some questions. Oh, wow. Okay. Let's go. Sir, I've got glasses off. It's just. Yeah. Sorry. No. Someone with the mic. Sorry. We've got someone with the mic already. First come, first served. Okay.
Okay. Hi, everyone. I'm Michaeline Holder-March, and I'm the founder of BAME Health Collaborative and also the Caribbean Global Institute. So this question is regarding ethnic minorities, because we present very differently in regards to the whole cancer pathway, and I have a very strong NHS background. How are healthcare systems in Europe and the UK working to improve the collection and use of ethnicity data among cancer patients, and what impact is this having on addressing disparities in cancer outcomes for ethnic minorities? As you know, we present quite late. You talk about accessibility and, and also treatment, and also that rich data that we're not always ready to give. So how and what are the plans in regards to addressing that, as we are all across Europe, UK, and everywhere? Thank you.
Equity is obviously a key aspiration, and implementing equity with regards to ethnic minorities, like myself. We can go along. Yeah, I think everyone wants to say something. It's okay. Let's try and keep it brief, though, because we've got lots of questions.
Okay. I think this is very good question. I think one of the things, for example, if you think about the personalized medicine, we think that is in a way one of the key elements, and we need the data. But referring to the 1 plus mg, I mean the 1 million genomes, we say that now we are too narrowed, so that we exactly said that there are many other countries, not in the Europe, solely not in Europe, but there are many other countries which said that we would like to share our data as well. So I think that maybe that is one of the things, but still there are many, let's say, questions still that we can reach the situation as you were covering. Yeah.
I mean,
Many.
we'll go, Matt. Yeah.
I was just going to say what you're talking about is really central, particularly because there's a proportion of the population that's responsible for significantly more cost or spend, rather, shall we say, particularly as we know in the NHS. And the digital divide we've got to be careful with, because there is a disparity and we're doing this. One of the things when we're talking about this in the European side of things is what have we done that is working that others can use and learn from. So this collaboration, this sort of meeting and our discussion is really important to be able to say this worked, this didn't, and either don't make the same mistake again, or how can we enable this to happen in another environment, and bring that local context to what you're talking about, because even across the whole of the UK, it's very regionally disparate, equally and more so when you enter Europe. So it's a learning collaborative as much as anything else.
Just very briefly on the racial ethnic minorities in terms of access to clinical trials. There's vast disparities, we know. At AstraZeneca, health equity is embedded in all things we do. It's not a box we tick or untick. And hence the dedicated investment into this with support lodges, accommodation, transportation, nurse navigators for clinical trials, really, and empowering clinicians who serve the underserved. And we're proud to have published data in the US showing that the Black American access to clinical trials is about 17%, which is above the Black American population in the US. And similar efforts are done throughout the world, including the European continent. So this is something that we'll continue to do, and I think it's absolutely important, along with the ageism problem that was mentioned earlier. And it really has to be benefiting all people. Otherwise, if it's just a niche population, it's not really going to be moving the needle.
Time goes too fast on these panels. We've got 5 minutes left. So, yeah, you, sir. And then if we get time to you, Mark, that'd be great. Okay.
Hi. Yes, I'm Anthony Conliffe. I'm a GP in England and a lead medical advisor for a national cancer charity in the UK. It was related to the patient empowerment point. So a couple of really brief link points. We've heard a lot about prevention and treatment and survivorship, but one big problem we certainly have in the UK, at least, is activation and engagement with healthcare. So not true access to healthcare, but how do we use data and all the things we've been talking about today to change behavior to, and I'm going to use the term now, but to empower people to feel more able to engage with healthcare. But on that term empowerment, I guess I'm going to ask for examples, because I think in the country, in the UK where I come from, I think it's a very overused term and a very, very rarely implemented process. So we will do a lot of work to enable, to inform, to support, to facilitate. but I could give you very few examples where we truly empower, where we are willing, and I mean we as big organizations, healthcare, health privileged groups, to share power, to hand over power, whatever that power looks like, whether it may be funding, etc. So if you've got examples of true empowerment, but I wish it in my country it was a word we use less, and we're way more transparent about what we're actually doing.
Okay, so let's keep it. We want to stick to an example. If you've got one, if you haven't got one, it shows a gap.
Yeah, I've got one.
Yeah, got one.
I've got the most catchy phrase you've ever heard. Technology-assisted patient-triggered follow-up. Okay? That was actually a pilot that we did with another national charity way back in 2011, using a web app, before we had apps, to have patients using prompts to trigger a clinical engagement back with their clinician. So this is right across the southwest coast of England, where patients couldn't come 6.5 hours back up into Southampton, for example, and they were triggering their symptoms using a prompt back to the clinician to empower that engagement. What was the enabler of that was the clinician saying, this is how I'm going to monitor you now. I don't need you to come 6 hours back to the clinic. If something's of concern, my clinical nurse specialist will be involved. She'll contact you, she'll triage you, and then I'll get involved as necessary. But that was back in 2011. And what it really bugs me is this is not mainstream. But it was an example of what can be done when we put our mind to it.
Right, yes. So this is someone's already engaged and then you keep them engaged. So yeah, okay, catch up with them afterwards and grill them on that one. Okay, Mark. Do we get the mic to you? 3 minutes left, by the way.
In the last 4 years, 50% of FDA-approved drugs have originated in university laboratories. Of those, 85% have been from US research laboratories. The Trump administration is going to cut 38% of NIH funding and 50% of NSF funding. How the hell are we going to produce new drugs?
Okay. Oh, I think we can take that as a comment unless someone has an answer to that question. Yeah, okay. We do have a problem with that. Sir.
Thank you. Nasil Alani, Aga Khan University. This question has in part been answered regarding inequities in the minority communities in Europe, predominantly in America. But the question is a bigger question in saying in Africa, the burden of cancer by 2050 will have increased by 150%.
Yeah.
The number of clinical trials being done there is less than 2%. The numbers that are registered on the trial center is only 20 since 2020. Really, Bob has partially answered the question as to what happens in the United States, but there's an economic opportunity, but also the fact that the burden in terms of the population increase is going to be huge in Africa. How are we going to address this? I know there are infrastructure issues and training issues, but we need to address this because that's applicable also to the populations that migrate in the future.
Okay, so that's a catch-22 situation. We haven't got the infrastructure.
Yeah, I think technology is a really helpful tool, and this also addresses the empowerment question. One initiative that we've invested in AstraZeneca is the MDT aid program, or multidisciplinary care, which is a pillar for the comprehensive cancer centers. You have different specialties targeting a singular cause, and you have different perspective. Then you have the best multidisciplinary treatment to improve outcomes. That's usually done in a room, but now we have telemedicine conferences, and AstraZeneca's embedded AI algorithms to really prompt help with ESMO, ASCO guidelines, informing practice really as prompts to help the discussion, help the clinicians, and store the data to help shape more guidelines in practice. And this is a program that really originated from Europe. And there's, in the lung cancer, we have a Lung Rosetta program that's now impacting more than 20,000 patients a year, helping clinicians, empowering the patients to get the best treatment. Now that program can be now copy and pasted to our Pan-American Cancer Consortium, now benefiting not only US and Canada, but all over the Latin America continent in diverse communities. And this really needs community physician engagement. The same could be done for Africa. This is really a digital era that a lot can be really, we can copy and paste with pride and really share data, share information, and to advance the needle together. And I think the data that can generate from that would be extremely valuable for patients in Europe.
Okay. We're going to have to stop there. We're out of time. But thank you very much for that excellent discussion. Key takeaways for me were about mindset shift, especially when we're under pressure like this in budgets and on political agendas. Mindset shift supported by evaluative data, which makes best use of what we have, and creative thinking around the technologies that we have that can enable equitable and better implementation of our aspirations. So thank you.
Thank you.
Thank you. Great discussion. Thanks so much. Yeah. Great discussion.